Sorry, PK, I couldn't include all those things, fit them all in on the title slide. Thank you for that title, however. These are my disclosures. PK, I have to pick on you one more time as well, kind of as a disclosure. I definitely do a lot of endo, but I also like doing surgical revascularization and bypasses. And I noticed that we weren't really having any discussion or too much about open surgery, so I thought it was just my job to point out that the best CLI trial, level 1 evidence that endovascular first is not appropriate for all patients, and that bypass surgery may be superior in patients with good single segment GSV. With that being said, let me tell you how I do tibial interventions. So this is actually my partner, Liz Genovese, and her setup, and she's really advanced our limb preservation program quite a bit. But when we're dealing with below the knee work, we're oftentimes going from antegrade access. This is a typical setup where we'd have where you can see the patient head to the screen left, patient foot to screen right, the work area set up, and that sets us up so we can nicely do antegrade access and see the entire leg, importantly, all the way down to the tips of the toes for everything that we're doing. Now, most of the time we start with an antegrade crossing approach. We like to get good sheath access where the sheath tip is just proximal to the lesion that we're going to start to cross. For the below knee, as I mentioned, we like antegrade access, either common femoral or proximal SFA if there's a disease-free segment there. We can do this up and over if we need to, but then you're using longer devices. Usually we'll put a 90 centimeter sheath in all the way contralateral down to the popliteal artery. And then we usually just start with a standard wire catheter advancing type technique. There's a whole host of different crossing techniques which have been discussed in some of the terminology. We like to stay intraluminal if we can, using just either wires, but oftentimes with support or the assistance of crossing catheters. If that's not possible, that's when we end up generally as a fallback taking subintimal routes to do the revascularization or the crossing. It's variable, and it depends really how hard you try, but somewhere between 40 to 80% of CTOs can be crossed intraluminally, up to 80% if you try hard. Some of the science behind this is into the cap morphology, and that can kind of dictate the approach and some of the devices you use. There is this CTOP classification looking at whether or not the caps are convex or concave. And then also, if you do histology on these occlusions, there actually are oftentimes microchannels, even though it looks like an occlusion, that can be utilized to traverse the lesion. The cap morphology has some implications because it may dictate or suggest whether you're going to be more successful from an antegrade or a retrograde approach, and oftentimes you need both an antegrade and a retrograde approach. Talk a little bit about wire basics. I think everybody doesn't need any one specific or particular wire, but there are different groups or platforms of wires that you need to be familiar with and have your one or two favorites in each category. So you've got to have your frontline navigation type workhorse wire that you usually start with. If you have difficulty engaging and crossing lesions, then you have to be familiar with and have a selection of some specialty or CTO or crossing wires. And then once you're able to cross the lesion, you oftentimes want to switch out to a more supportive wire to deliver whatever therapy you need to deliver. I'm not going to go over all the individual wires. You got to pick one or two favorites of your frontline or workhorse wires. I usually like the Command wires as my workhorse wire, but we use a variety of these, and we stock several of these. The GlideWire Advantage is another one of my favorite workhorse wires that I use. In terms of crossing wires, there are ones that are going to have very tapered tips so that you can engage microchannels, and then there are also ones that are going to be have heavy tip weights so that you can use them kind of as a drill that give you a lot more force to penetrate to cross the tougher proximal or distal caps. And then, of course, I mentioned support wires, and those are ones that you'll place once you've crossed the lesion. They give you a lot more support backbone so that you can deliver whatever therapy you need to deliver. And sort of a lot of people talk about this wire escalation. So you start with your usual workhorse type wire. If that goes and you cross everything, great. But if not, then you start switching to these specialty wires using the tapered tips and heavier CTO wires to be able to cross things. And if a tapered tip wire by itself is not enough, that's when you go to the heavy tip weight penetrative tips. And so that gives you a lot of force, so you can kind of try to puncture and break into that impenetrable cap. And some of the different wires in each of these categories are listed on this slide as well. So, you know, the wire probably is going to change throughout the recanalization process. If it's a tough CTO wire, first you're going to have your strategy to engage the lesion cap. Oftentimes we're trying to do that if we stay intraluminally by accessing via the microchannels using your workhorse or a tapered tip wire. If you have difficulty engaging that true lumen with any of those techniques, that's when we start going to the heavier tip weight CTO wires. Once we get past the cap and we're trying to traverse the lesion, if you have a heavy tip weight wire, oftentimes we'll switch back to a more workhorse wire so that we have less chance of perforation as we're crossing the lesion. And then certainly when you get to the end, if you just don't automatically re-enter into the true lumen, then you may have to do some work with different wires to be able to re-enter into the true lumen. And sometimes that's not always possible, and we'll talk a little bit later about re-entry techniques and alternative access. Support catheters are also key as well. There's a different selection of these. Everybody has their favorites, but as you're advancing your wires, you're backing it up with a support catheter, both to enable you to exchange wires and also to give you support while you're crossing. And so you can kind of pick your poison, which one's your favorite. We don't stock all of these, but we have a couple of these on the shelf that we go back and forth with. If just with wire support catheter technique is not successful, there are some specialized crossing catheters. A lot of the different crossing and reentry catheters are probably more applicable to the femoral popliteal segment, but when you talk about tibial CTOs, there are some specialized catheters, and I've shown two here that have been described as being successful, and that some people like the wing band and the BBAC catheter. And a lot of these can use either stiff needle advancement or drilling motions and things like that to help traverse a lesion that you can't traverse with wire alone in an antegrade approach. But of course, sometimes any of this may fail, and that's when the utility of retrograde pedal or tibial access approaches come in place. There are a lot of people who may start primarily with a retrograde, direct tibial or pedal access. We don't generally do that in our practice. We usually do give a initial antegrade approach, and if that antegrade approach alone fails, that's when we'll add in the additional retrograde pedal or tibial access. Many of the occlusions that you can't cross from an antegrade approach can be traversed intraluminally and crossed relatively easily from a retrograde approach. We typically use this just for crossing to get across the lesion, and then usually treat primarily from an antegrade approach once we've crossed the lesion. But you can treat primarily from a pedal approach, and there are some that do that. But in my mind, before doing that, I'd want to really ensure that that's not the patient's only runoff vessel to their foot before I start putting large sheaths and upsizing to deliver therapy from the foot or a tibial access. These have been well described, and actually the Leipzig group with Dirk and Andre and even Miguel Montero Baker, who's going to be doing the live case, have taught us a lot from a number of years ago that retrograde access was possible and showed us how to do that. Sometimes we'll use a proximal AT. That's usually not for BTK cases. That's usually for popliteal occlusions. Usually we're more distal when we're dealing with BTK disease, and you can take any of the vessels, AT, PT, perineal, wherever you can gain access. Perineal can be more difficult, so more often than not, it's AT or DP or the PT that we're utilizing. When you go retrograde, you have to have the appropriate materials and supplies available. So as soon as I access the vessel, I usually go straight to an 018 wire. I don't use the wire that comes with the micropuncture kit. Sometimes you're going to be using a hydrophilic or a CTO heavier tip-weighted wire, depending on where you are and what the disease is. Primarily, I go sheathless and just use a support catheter over my guide wire once I've gained access, but you also can introduce a sheath, either the pedal access set, which is really just a micropuncture sheath, or if you need to go larger because you're delivering therapy, sometimes the low-profile glide sheaths can be useful. There are a whole host of low-profile balloons that you can even introduce through that 2.9 French micropuncture sheath. And then every time we gain access, we inject radial cocktail, and we use plenty of local anesthetic to try to prevent vasospasm once we enter these small tibial vessels. How to get into those vessels? You can also choose whichever technique you utilize. Ultrasound, I think, is very good, but if I have calcified targets, oftentimes those can be easily seen under fluoroscopy, and also you can combine that with some antegrade injection of contrast to be able to access using angiographic guidance, but certainly having a good hockey stick type probe, high frequency, so that you can get a good visualization of the small vessels. You can use ultrasound guided access as well. And so I think it's good to be facile at both techniques because sometimes one will work better in a patient versus the other. In terms of when I decide to use a sheath, my default is to go sheathless and not to upsize the access, but certainly if we're doing a more complex case from retrograde, I will use a micropuncture sheath or a dedicated pedal access sheath. I think if we're doing lots of exchanges, it may actually protect the access site in the vessel from the trauma from the multiple exchanges, and actually facilitates the exchange of support catheters and balloons and other devices if you need to do that from your pedal or tibial access. And these are compatible with low-profile balloons, so if you have low-profile coronary-type balloons on your shelf, then you can deliver them through these smaller sheaths. Here's an example of a patient with some complex disease, really a trifurcation occlusion of the distal popliteal artery, all tibials occluded, but reconstitution of a nice posterior tibial artery that's actually going to supply. You see a little bit of a wound blush there on the heel where the wound was in this particular patient. This was accessed using ultrasound. And then in this case, I knew it was going to be more complicated. We do have the 3 French pedal access sheath for support. Ultimately did end up going subintimal because we weren't successful in crossing this intraluminally. Then it gets a little bit more frustrating because then you can't re-enter when you get up to the distal popliteal segment. Here you can kind of see the wire that's tracking outside, and for the life of me, I couldn't regain access to the true lumen there. So there are a variety of different techniques that have been described as re-entry strategies when you have difficulty just with a wire or catheter re-entering the lumen. There are certainly re-entry catheters. I think those are much more difficult with below the knee type disease, but there's a whole host of different techniques, these rendezvous, safari, cart, reverse cart, antegrade cart, double balloon techniques. Pick your poison. Sometimes you can, one's going to be better than the other. And then this other one on the far right called target or facilitated re-entry, where you use a balloon as a target and then a re-entry device with a needle entry into the balloon. This is an example of a facilitated re-entry case that I did. I think it's actually the case that I'm showing you. Here you can see that we've delivered a low-profile balloon from the pedal access approach. We're in the subintimal plane. This came down the true lumen with the re-entry catheter. We can fire the needle aiming at the balloon. Once the needle is in the balloon and has ruptured the balloon, you'll see that. Then you can advance a floppy 014 wire and coil it inside the balloon itself. And then as you advance the wire, you can retract that balloon from the pedal access, and then that establishes the re-entry and the through wire access. So just an example there. So usually once I've crossed and I start my therapy, that's when I give up my retrograde access and start working on getting my hemostasis so that we don't have to spend a lot of time after the case to get hemostasis. A lot of times I use a pneumatic tourniquet that I inflate to low pressure, and then periodically during the case, you can deflate that tourniquet so that by the end of the case you know that you have hemostasis when you're doing your final run. So as I'm occluding the vessel by doing the angioplasty, I'm removing my access from below. Once I've reestablished guide wire access past that tibial or pedal puncture site, we'll apply the tourniquet. Depending on the location, you can use TR bands as well. Or similar devices. You can put 2 TR bands together with the Velcro to make a bigger device if you're going around an ankle or foot in somebody in whom a TR band otherwise wouldn't fit. And here you can see that case after we recanalize that occluded posterior tibial site. You see the access site, maybe a little spasm at that area, but usually that turns out not to be an issue, and it's pretty rare actually if you use appropriate technique to damage or to lose your targets. One final thing I'll talk about is transcollateral or kind of pedal loop access. So in this case, you see the panel on the left that the posterior tibial artery is occluded. unable to cross that antegrade. You can't actually go retrograde without a separate puncture if you traverse the pedal loop. If you do this, I do think that you really have to know your pedal and your foot vascular anatomy, and you have to use precise, meticulous technique because you don't want to damage that pedal loop. If you cross that subintimally and damage the pedal loop, you'll take a case that you could have salvaged, and otherwise that patient could lose their foot. So have to be familiar with the anatomy. You also have to be familiar with how to visualize the arteries in the foot and the pedal loop, how you're traversing. There's going to use two different projections. This is the AP projection where you can see if you're coming from the DP, that the connection with the pedal arch there is usually between the heads of the first two metatarsals in that view. And then the lateral projection is where you're going to watch as you're traversing back after you've crossed that pedal loop into the lateral plantar artery to get back up into the posterior tibial artery. And I think I've talked enough, and with that, let's move on.